Good afternoon, everyone. We are running late of schedule, and I'll not eat up your lunching time. So, I come from an institute which is just across the river, and probably we do tracheostomy more in number in the zone, probably in the country. So, what does that mean? By the term tracheostomy by dictionary, it means the surgical formation of an opening into the trachea through the neck, especially to allow the passage of air. And if it is crosses the skin marking, we call it tracheotomy, but for practical term, both are same as per the Webster dictionary. So, although in our institute in 13 years we have crossed the maximum number in terms of the number, but it started long back. By the term Greek origin means tom to cut and stom to the mouth. And it also mentioned in the Rig Veda even before the paper have started inking. Alexander the Great also have done in the history, but we need to know how we do it now. So in the present era, there are some references leading to George Washington's death. The President of America died because of acute epiglottitis, because tracheostomy was not done in him and was not done in certainly other patients, was dying because of diphtheria. It is not because of the diphtheria, it is more because of the upper air obstruction. But when it was started in them, they could have saved like 47 patients out of 215 with diphtheria. So the vaccine was not there, so they saved multiple number of patients. Then in the last century, what happened is that the tracheostomy term was coined, and they started doing tracheostomy mainly for upper airway obstruction. Because in 1900, the polio epidemic happened, and since then, in the last century, three major developments happened. So how it happened? Because of the polio epidemic, patient was dying because of acidemia. People didn't know how the patient is dying. They thought it's because of renal failure. Then the iron lung happened, and it saved many lives. You can see in the picture. But then again, because of the vaccine was not available in most of the world, but the iron lung was very much popular across the world and spread up across the world. But in that time, even in Copenhagen, only one iron lung was available across the city, when 6 to 12 patients were admitting daily for respiratory failure secondary to polio. So you can imagine it is basically a replica of the COVID era when the ventilators were scanty. So at that time, Dr. Ibsen John was recently passed medical graduate after anesthesiology degree, came back from Boston. He was called for basically treatment of those patients. And he accumulated all the patients in a single area where people were trained to do hand ventilation through a tracheostomy. And they were working in shifts, and there was a shift in the ventilation from negative pressure ventilation to positive pressure ventilation through trachea. And that showed that if you accumulate trained people in a single place to treat patients who require ventilation, you can save many lives. They started hand ventilating. After 31 failures, the 32nd patient basically survived. So that changed the era of ventilation, and that changed basically the era of ICU. It started then. So first time in the modern era, back in 1969, Dr. Toy and Winston, I'll call later how they did it. They started doing the percutaneous dilatation technique of tracheostomy. We do some modifications, but basically we do it in their way. So why we do it? We do it to relieve mainly upper airway obstruction. We do it to prevent the laryngeal and upper airway damage, because at that time mainly it was not a polyurethane tracheal tube, and it is not having a low pressure cuff. So when you used to use for longer duration of ventilation, it can cause mucosal injury, especially in the vocal cord, and that may ultimately reduce the vocal opening. So you can do a tracheostomy to save the vocal cord, even if you are doing it for longer duration of mechanical ventilation or for even oxygenation. So also it helps in basically removing the secretions from the lower part of the respiratory tract, and it gives a stable airway over a longer term. So in the easier way, what we do is we reduce the obstruction from the pharyngolaryngeal lesions from the upper airway. We relieve the oropharyngeal passage to reduce the sinusitis. Ultimately, we open up the glottic opening, so we reduce the sedation to the patient. It increases the comfort to the patient, and ultimately, we think we reduce the ventilator-associated pneumonia and the duration of mechanical ventilation because we reduce the sedation in these patients, and of course, it helps in early mobilization of the patient out of the ICU beds, decreases cost, and ultimately we think we decrease the hospital mortality. So when not to do it? Basically when you think the patient cannot tolerate it. Patient is hemodynamically unstable, ICP is too high, patient is having severe hypoxemia, the PEEP level is too high, it is better not to do it. Sometimes we think that we cannot do it when the patient is coagulopathic, but if it is needed, definitely you can do it with some transfusions. We fear of doing it when the patient is morbidly obese, but of course we can use some adjuncts to make it easy. So when the neck anatomy with some thyroid mass or with some other swelling is altered, or if the patient have an unstable cervical spine, we cannot extend the cervical spine, or maybe the patient already had a cervical surgery with some implants and the approach is through the anterior part of the neck, which may hinder with the surgical approach. It is better to avoid percutaneous tracheostomy. You call upon the surgeon for the surgical tracheostomy. But of course, when you don't have the consent from the patient family, because patient cannot give a consent for tracheostomy, and of course, if there is an obvious infection at the site of your incision, it is better to avoid the percutaneous tracheostomy. And when you think from the primary disease, the patient is going to die. So you can select your patients, whether the patient is a Guillain-Barré syndrome or a myasthenia gravis on long-term ventilation, or whether this patient is having basically motor neuron disease which is going to die in few weeks. It is better to avoid. So before we go into the detail of whether to do tracheostomy or not, it is a big debate how early to do it. Whether early tracheostomy, which we mean by international definition less than 4 or 5 days, or by Indian definition less than 7 days, I'll talk to you later why there are some different definitions. Whether it reduces ventilator-associated pneumonia. So you can see in this forest plot, the black diamond is basically in the midline, statistically insignificant, favoring early tracheostomy if you do it 4 to 5 days into your mechanical ventilation. So if you call the relatives and say that, okay, if you do tracheostomy, the chances of pneumonia will go down, probably it is not there. Second, basically a Chinese population study which also showed that if you do a early tracheostomy, probably different studies have shown that it is not a statistically significant reduction in the ventilator-associated pneumonia. So when to do it early? So this is basically another study which have shown that if we do early tracheostomy, it may increases pneumonia. So you have to select your patients, and when you see the risk of pneumonia and other things are low, then only you go for a tracheostomy. The timing is not that important. But whether it reduces the length of stay, yes, it reduces the length of stay because ultimately it reduces the ventilated days. So this is the same of the group from the Griffith and all who did a systemic review and shows that early tracheostomy definitely favors in the reduction of the ICU length of stay. And the recent, basically, another study by the Liang Meng et al., who have shown in a systemic review that even though it is not statistically that much significant, but even it favors early tracheostomy, which by means less than 5 days within the mechanical ventilation period. So this is a different study population. You can see in the Indian study, mostly from the Pune and Bombay, they did in neurotrauma patients, and definitely in them, the length of stay in neuro ITU, there is a reduction. So in subpopulation of neuro patients, when you think the prognosis of the neurological injury is good, you can reduce the ICU stay with early tracheostomy, and then of course it improves the patient outcome. But this is in contradiction to the European study. This is, you can see in the number, this is by our boss, Brian Cuthbertson and all. This UK-based 70 centers. They did over 4 years research with 900 patients only, and they found that the mean ventilator-free days is not statistically significant. It is compared to RD, which is less than 4 days, versus more than 7 days of tracheostomy. They had the same idea, which is not proven by different systemic review and across the world study. You can see that if you do a RD tracheostomy, which is less than 4 days, it ultimately reduces the ventilator-free days. Patient becomes mobilized early. So this is in accumulation of all the patients they studied. In the recent study also in around 2005, they found that as the ventilator days goes down, the ICU length of stay also goes down, and that is quite statistically significant in the RD tracheostomy group. So when you think the prognosis and the disease is separate, and they can benefit for tracheostomy, if you decide for tracheostomy and the patient requires it, it is better to do early. So in different subpopulation, like neuro patients who had undergone decompressive craniotomy and could be debilitated for months or years, this is a group from Pakistan, they have also proven that the patients who require ventilator more than 12 days, it is better to do tracheostomy early. And that also replicated in the Cochrane database. They have shown that early tracheostomy decreases the ventilator days even in a short-term period, even like within a month. So ultimately it reduces the ICU cost, but which is not replicated in terms of mortality. So you can see the same group, the Cuthbertson and all, in the TrackMan trial. They studied the patient over 2 years, and they have found that the mortality, whether it is for up to 30 days, till ICU discharge, till hospital discharge, 1 year or 2 years, the mortality is increasing up to 50% at the end of the 2 years, but they are not statistically significant. And of course, you can see none of the values are significant there. You can see in this, the survival rate of the patients go neck to neck like a one-day match, and the early versus late tracheostomy are not much different. But we are not talking about early versus late. We are talking about who needs it, get it early. So in the Cochrane database, which is in contrast to the TrackMan trial, have shown that ultimately when the patient's mortality is concerned, whether the short term or in the medium term in terms of 1 year, it is better to get early tracheostomy. It reduces the mortality. So what about the subpopulation of patients who are basically intubated for neurological lesions? So this is a study they have shown that early tracheostomy neurological population is better. So they have basically calculated score named SET, stroke related early tracheostomy score, based on the neurological diagnosis and the other vitals diagnosis. They have formulated score, and based on that, when the SET score is more than 10, they have asked the patient to get early tracheostomy done, and they found that in that subpopulation, early tracheostomy is always better. But this group, which is basically made the first trial, like the TrackMan trial, they wanted to prove that wrong in this subpopulation of patients which had severe stroke. And they basically a Germany-based 29 ICU trial, and they've actually found out what could be the functional outcome at 6 months. You can imagine the tracheostomy is not going to change the functional outcome. It is the functional outcome depends on your rehabilitation group, your nursing status and all. It is not about tracheostomy. So probably it is not the primary outcome data should be looking at. What they found that early tracheostomy didn't change the primary outcome in terms of survival with significant disability. At 6 months, both were similar. So how we do it? The techniques are different. They are getting modified, and as it is a technique, as you do it, you learn by mistake, and you get better. So how we do it? So this is a meta-analysis which have found that percutaneous tracheostomy should be the choice in ICU. Why is that? There's a comparison between surgical tracheostomy and percutaneous tracheostomy. You can see that in terms of major post-procedural bleeding it favors percutaneous tracheostomy. It is higher in the surgical tracheostomy group, although they had a cautery. So organize a surgical tracheostomy, you have to book a OT, you should have a trained surgeon with time. So the technical difficulties are much more surgical tracheostomy. But as the stoma is smaller with percutaneous tracheostomy, the stoma inflammation, stoma infection are much more lower in the percutaneous tracheostomy group. So if you have to do it in the ICU, percutaneous tracheostomy has to be the choice. So Indian trial, we did the dissect, we'll call it later. So there is a cost difference also. The percutaneous tracheostomy cost-wise around 13,000 rupees cheaper. So it is better for the patient relative to get convinced that in the ICU we do percutaneous tracheostomy. So how it started? It started around 1960s, a 100 population study by Frederick John Tway and Winston. They had this device developed, which starts with a dilator, basically with a tapered end, the carved one in the left side. Then they had a special tracheostomy tube, which is smaller, which is side hole, like an eye of endotracheal tube, and they had a syringe with the needle can be split up. So how it started? It started like you insert the syringe in the trachea, you aspirate air, then the dilator with the side hole of the tracheostomy tube insert through the needle. Then in the figure 3 you can see you take out the needle, split up, only stays inside is a dilator, and the tube is just attached to it through the side hole. Then in the figure 4, you gradually insert it with the dilator, the tube goes in, then through the tube, the dilator comes out, and then you secure the tracheostomy tube. So whatever we do a modification of this technique only. Only in the 1 year later, Dr. Ciaglia also developed a similar kind of but less complicated method. You can see in the picture, there is a guide wire, the J wire at the bottom. Then there is a snugly filled 8 French catheter, and beyond that there is a tapered end dilator, and the dilator outer diameter is snugly fitting to the tracheostomy tube. So altogether it is a single dilator technique which you use now to insert the tracheostomy tube. So, but you can imagine this is not actually a tracheostomy tube modified. This is a nephrostomy tube which was used for single dilator technique. That got modified with multiple dilators, and nowadays probably we have this, what you call a white rhino or blue rhino. This is a single dilator tapered end, which is very smooth and slippery into the trachea. So we'll basically probably discuss in more details about the techniques in the workshop. And then a couple of years later, in the southern part of the world, Dr. Griggs developed this forceps, which they call it subcricoid mini surgical tracheostomy. So with the hole in between the forceps, the dilator forceps, the guide wire goes in, it comes out to the curved end of the eye. And then we use this dilator forceps basically for dilating the anterior portion of the surgical hole. So if you can imagine that the maximum part, the guide wire open at the tip. So you have to basically dilate the anterior portion of the tracheal hole. So if you insert it too lower into the trachea, it will not dilate the anterior wall of the trachea, it will dilate the lateral wall of the trachea. So you have to be cautious where you are dilating. So as you get trained, the amount of pressure you give in will also be controlled. But so that's why the Ciaglia process is much more probably safe. So how we do it now in India? So you can see we did basically a 3 months trial a couple of years back, and we found that the single dilator technique is most commonly used compared to the multiple dilator and also for the Griggs forceps. So if you compare the Trackman trial, which used basically 4 years study with 900 patients, we in India can research much more better. In 4 months, we collected 900 patients. And in that, the single dilator was the first and most common technique to be used. So in studies, if we compare which percutaneous technique is better in a systemic review, we found that in terms of technical simplicity, Blue Rhino is better. But if you compare the overall major bleeding with Blue Rhino, because it's a single dilator, you don't know how much to get it inserted, all the dilator systems are mostly similar in terms of complications. So probably nowadays that's why we commonly use the single dilator blue rhino technique. Do we need any adjunct to that, and which one is better? You can see in the dissect trial, mostly we use the fiber optic bronchoscope. You can see whatever you are doing. Also, some people use the ultrasound to look into the vasculature, short neck, obese patients. But if you have both, better to use both, especially in the learning curve. So it's a color picture when you insert the bronchoscope. First, you insert the bronchoscope and see till the carina whether the tube is in place or not. Then basically you take out the bronchoscope just before the tip of the endotracheal tube, so that it doesn't get hard during puncturing. So in the upper middle picture, you can see the bronchoscope is inside the endotracheal tube, and you are bringing it up till the cricoid ring, or maybe in the first ring. So if you closely look in the bronchoscope, whoever is not doing commonly, you can see there are a bit lighter white semicircular marks. Those are the cartilages, rings, and in between there is red semicircular marks which are the intercartilaginous membrane. So ideally you should hit at the middle of the intercartilaginous membrane, not in the cartilage, otherwise you will hit the cartilage. And you can see when you are puncturing the trachea, ultimately the diameter gets reduced. So there is always a chance of hitting the posterior wall when you are compressing on the anterior wall of the trachea. So be cautious on that. So when you are basically going through, you can see the guide wire going in, not going anywhere else. It is not puncturing the lateral walls. Then gradually the blue dilator goes in, and ultimately when you see the tracheal tube goes in, and the lower panel, you can see the diameter is greatly reduced. So be cautious about injuring the posterior wall, and bronchoscopy always help in doing that. And then you basically do through the tracheostomy tube and see that inside there is not much bleeding and everything is fine. Then you take out the bronchoscope. So what are the other adjuncts we can use? Of course, the ultrasound and the radiologists are better to describe that. So first we localize the hyoid bone. You can see the brown mark is the hyoid bone, and below the purple one is the thyroid cartilage, and in between the hyothyroid membrane. Then you basically make it transverse and see the thyroid cartilage, which is much more triangular in shape. And you can see actually the arytenoid, the green circles there. So it helps in localizing the thyroid cartilage and vocal cord. Then you go up in the basically in the up slide, you can see it, make it longitudinally, and you can see what is the thyroid cartilage. The purple one is the cricoid cartilage. All looks beaded in appearance with black circular rings, and in between the brown line is basically the cricothyroid membrane, and then the basically blue dots are the thyroid cartilages. So you localize them and you localize where to hit them. At the same time, also you look for the vessels there. If you put a Doppler, they will be pulsating, the arteries and veins. So if you are puncturing lateral, not in the midline, probably you have a risk of injuring the vessels. So be cautious about that with the ultrasound. So if you give an option then what to use, ultrasound or the bronchoscope, you can see that bronchoscope sees from the inside, doesn't tell about the blood vessels. The ultrasound tell from outside, it's a black and white picture from the outside, but it doesn't tell what you're injuring inside. So probably both is better. So this is a single center study, I'll say, from around South America. Very small in number studies. They compared neck to neck between the both. Of course, the procedure whoever is doing may be trained in both. The complications are not much different whether you use ultrasound or in bronchoscopy. But if you have the scope to use both, better to use both. So you can see also in this diagram that in terms of risk, whether in the intention to treat analysis or a par protocol analysis, exactly the black box stand in the midline. So if you learn higher and higher, your skills better even with a blind method. So are you ready to know more about it? How we do it? We get a consent form done. We get a monitoring sheet done. We get the drugs ready. We get all the emergency procedures ready. Then the set is ready, proper size of tube is there or not. Patient is ready. First you have to do a better oral care because the patient is lying with sedation, no swallowing movement. You have to clear the buccal folds and all to reduce the bacterial burden because you are removing the tube, mobilizing the tube, and at that time there may be sudden aspiration and bacterial pneumonia during the procedure. Sometimes patient may vomit, not purely kneel by mouth for adequate time, and high acidic gastric secretion can come out and basically fill up on the cornea, causing corneal ulcer. So we have to basically cover all the things which can get injured. We have to ask whether everybody is ready with the things. We have a special infection control nurse who comes in and see whether everybody is dressed properly, washed hands properly, cap is everywhere on there, and all the checklists are done or not. So when it is done, you go with the procedure. So how to do it? You ventilate the patient with 100% oxygen. I'll go in the technique more in the workstation. You give a midline incision, and then you gradually proceed with the procedure to get it done. Check it with either fiber bronchoscopy or a capnogram or simply by auscultation, and definitely a post-procedure X-ray. So not only doing a tracheostomy is important, it is better to know when to take it out. I'll just briefly touch upon that. We have basically ENT specialists with fiber optic laryngoscope who they put in and see at the time of decannulation, maybe a few months later, whether both the vocal cords are moving equally, whether the patient is aspirating or not before going into the decannulation. So how to do a decannulation? There is study. Basically they judge about the timing of secretions, maybe 2 times maximum in 8-hour period, and then they assess the readiness of the decannulation few months later. And they found that in the intervention group, when you assess the number of secretions patient is having, the patient is having adequate swallowing, patient is obeying to you, you basically deflate the cuff, assess the patient swallowing, block the cuff for maybe 24 hours, and see whether the patient can bring out the secretion till the tracheostomy tube, patient can have an effective cuff, and then only you can think of decannulation. So this is a better method of decannulation, maybe a few months later. So we did some recommendations with our DISSECT trial, and basically we started with the indications, choices between surgical tracheostomy and percutaneous tracheostomy, which guidance or adjunct to be used. We assessed the complications and also assessed the average cost, and also we guided about the tracheostomy in special situations like coagulopathic patients or obese patients. In that we found that basically the complications are pretty low with percutaneous tracheostomy, and it goes lower when you get more trained. And of course, we use some special devices also to reduce the complications, like this is basically an adjustable flange tracheostomy tube. The patient, when he's sick, getting a tracheostomy may be much more thicker, swollen neck and face. Maybe a few months later, he's thinner. So if you reduce the basically size of the tracheostomy tube or length of the tracheostomy tube, sometimes it may get out. Or the patient is too much swollen, even also then the tracheostomy stoma site and the distant site may be changing. So in that case, basically this adjustable flange tracheostomy tube really helps. So you really have to know how you're doing it, which technique is better, and how to avoid your complications. Thank you. Probably I've enlightened some questions and invited for more during the workstations.
Okay, probably doubts would be cleared more on the workstations. May I request Dr. Pierre to please felicitate Dr. Nilanchal. A big round of applause, please. Thank you very much.